Oh yeah. How are you?
Hi. All right, I guess I'll start. I'm Harvey Risch. It's a pleasure to speak with you today. I appreciate the invitation. I'm talking about my title is Hydroxychloroquine and its friends. And if there's anything that ever needed friends, I think this is it. Let me start by describing conflicts of interest. I want to say that I have zero, none. I have no drug company relationships, no planned relationships, no payments, nothing, no marketing products, nothing. So we'll just leave that at that. I want to start by saying why I'm actually speaking to you, how I got into this in the first place. I'm not really an infectious disease epidemiologist. I'm a cancer epidemiologist. For the last 40 years, I've mostly done research on ovarian and pancreatic cancer, also lung, bladder, stomach, esophagus, and so on. But after medical school, I decided to get a PhD in biomathematics and biostatistics. And my dissertation work was on mathematical models of infectious epidemics, and I published on this back 40 years ago. And this, although it's kind of under the radar for most people, has actually given me a bit of credibility to talk about things like herd immunity. And in fact, people don't understand what herd immunity is in general. It's actually the peak of the epidemic curve. The epidemic curve is described by these equations in the simplest form. And what this means is that herd immunity, here's your epidemic curve, herd immunity occurs here at the top, not down here when we want everything to go away. Of course, we want it to go away as fast as possible. But herd immunity starts here. Herd immunity is not enough for the epidemic to go away. It's enough to make it to start to go away. And that's what's important to get over the top. In any event, in March of last year, the Connecticut Academy of Science and Engineering, which I'm a member, made an expert panel to advise the state and the governor about how to reopen the state after our lockdown. And I was selected to be on this panel, and I started thinking about COVID and managing it and so on. And I rapidly came to ideas that were somewhat different than the other members of this panel. And what first caught my eye was your original paper, uh, this one that was out early last year about hydroxychloroquine and azithromycin as early outpatient treatments. And when I looked at your table of the actual individuals and their testing, I realized that I could analyze that by Cox regression, survival time regression from those data. And when I did that, it was obvious that hydroxychloroquine and especially hydroxychloroquine plus azithromycin was associated with a shorter time to the first stable negative PCR status, and that was adjusted for clinical status, age, and sex. And then I discovered that the Chinese had actually been studying hydroxychloroquine itself for some time, had shown effectiveness in limiting viral replication, at least in vitro studies. So over the next 5 to 6 weeks, I reviewed everything that I could find about efficacy and safety of hydroxychloroquine in COVID, but something seemed very strange to me. These studies were being published about the drug in hospitalized inpatients, but then the conclusions of the papers and the media reports about them were generalizing to all COVID, all patients, both ambulatory outpatients and hospital inpatients. And even then, we knew that the disease had multiple stages in which outpatient disease, which is the viral replication flu-like phase, was different than the hospital acute respiratory distress syndrome florid pneumonia stage, and they needed different treatments. So I didn't understand why this discrepancy was going on. Also, about that time, Dr. Zev Zelenko had started publicizing his experience, his personal treatment experience in treating patients in his upstate New York community. He was using hydroxychloroquine, azithromycin, and zinc, and the media messages started popping up saying that his regimen didn't work, and then they would cite for reasons why it wouldn't work that only studies that looked at hydroxychloroquine by itself. So at the time, I was naive. I thought that this was just sloppy scientists and sloppy reporters. And so I set out to formalize a review by being detailed about everything, about outpatients, about early use, high risk people, hydroxychloroquine plus azithromycin, not hydroxychloroquine alone, and so on. And this led to my paper from May of last year in the American Journal of Epidemiology. And you can see in the title that I was, as I said, very specific. Early, outpatient, symptomatic, high risk. All of those details are crucial. Now, this paper, to be totally transparent, was not sent out for external peer review, but it was blindly reviewed. It was submitted without a title page, so it was blindly reviewed by editors of the journal, and so they were the peer review. And they, in normal peer review, identified issues to be fixed. I complied with that, revised the paper, and resubmitted, and then it was accepted. So this was peer reviewed. It was just not in the external way that is usually done. In the paper, so I had available your original study, the second study of the 1,061 cases, the initial sample of Dr. Zelenko's 1,450 patients, that about 400 were classified as high risk, the study of 636 symptomatic high-risk patients in Sao Paulo, Brazil, that's the Prevent Senior study, and the small study of 54 patients in Long Island, New York nursing home who were treated with hydroxychloroquine plus doxycycline. And the analysis of this was totally consistent. Every study showed the same thing. And I asserted in my review that these results were definitive for a benefit of early treatment of high-risk outpatients with hydroxychloroquine plus antibiotic. And it was patently obvious because the hospitalization and mortality risks at the time were hugely greater than what these studies were showing. However, by doing this, I lost some friends, so to speak, and this was in part because some of my colleagues didn't think that I had enough data to make the case that I was claiming. However, this AJE paper very quickly became the highest ever altmetric score paper in the AJE journal, and it's now been downloaded more than 88,000 times and viewed 136,000 times. It's the most of any paper in the AJE, so it's got a fair amount of coverage. Okay, now even with the amount of data that we had back in June of last year, so it was clear that hydroxychloroquine plus, I call it plus to mean with antibiotics, with zinc, with what other components of the treatment regimens people use, that it provided appreciable benefit in reducing outpatient risks of hospitalization and mortality. And then strange things began to happen. I started getting lots of emails from doctors saying that they agreed with me or that they'd actually been using hydroxychloroquine for their outpatients and it was working. At the same time, I started getting public criticism by what I'll call talking head doctors on mainstream US media, including Dr. Fauci, who had been saying that any study that's not a randomized controlled trial was, in his words, anecdotal. Anecdotal is his code word for junk science. And this whole point of saying anything that's not a randomized trial is junk science is obviously nonsense, that any competent medical scientist knows there's other kinds of studies besides randomized trials. And then the news channel, CNN, asked me for a TV interview, and I already knew what that would be about, that they would try to manipulate the circumstances of the interview to make me look bad, to discredit me, because they had already done that to Dr. Peter Navarro, who had been trying to get the U.S. hydroxychloroquine stockpile opened up for general outpatient use. And I had watched that interview, and it was pretty nasty. So I went ahead anyway and did it, and I don't intimidate easily, and so I argued back strongly enough, and apparently people who watched the video said that they thought I was being bullied, not being interviewed. And then this science war against hydroxychloroquine started. So more studies started coming out. Normally they would be published, but over the last year, the scientific journal publication has been totally corrupted. Medical papers publication has been totally corrupted. So anyway, these papers started coming out showing benefit of hydroxychloroquine, etc., in early outpatient use. And then other studies started coming out claiming that hydroxychloroquine showed no benefit or actually was harmful. And we know this from the fake Surgisphere papers that were retracted. And these negative papers were quickly reviewed and published in journals like Lancet, New England Journal, JAMA, and so on, other top journals. which at the same time were refusing to publish the positive hydroxychloroquine papers, and they were refusing to publish letters to the editor criticizing the negative papers. Also at the same time, the hydroxychloroquine political and policy war had been going on and was continuing. So we know that in March of last year, President Trump ordered BARDA, which is one of the U.S. Medical research and policy agencies, to release the U.S. Strategic National Stockpile, which at the time had 60 million doses of hydroxychloroquine. This order was conveyed by the Secretary of Health and Human Services, Alex Azar, to the director of BARDA, Dr. Rick Bright. However, Bright didn't do that. He secretly conferred with Dr. Janet Woodcock, who was at that time head of the Drugs and Therapeutics branch of the FDA, and Woodcock told him not to request the FDA approval for the use of the hydroxychloroquine that he was instructed to, but to file an early use authorization for hospital use only. And she did this knowing that the drug worked less well for hospital patients than for outpatients. So this was insubordination, and Bright has actually said this in public, that he's proud of having done that insubordination. Now, this EUA emergency use authorization was secretly submitted at midnight to the FDA. It was approved 30 minutes later by Woodcock with no agency discussion. And the action by these two conspirators is what blocked the use of hydroxychloroquine for outpatients. But as if that wasn't enough, the FDA mounted a fraudulent website. And that's, I'm showing here, this website is still up. It says that the FDA cautions against hydroxychloroquine for use outside the hospital setting, meaning in outpatients. And then if you read the reasons why, it says that only because they have data about adverse events used to treat hospitalized patients. And so this is a fraud. This is an outright fraud, because we know that outpatient disease is totally different than inpatient disease, that the benefits of using hydroxychloroquine after 7 or 8 days in people with florid pneumonia, whether or not, whatever the review of that circumstance is, it's totally different than the use in the first 3 or 4 days of the outpatient viral replication phase. And therefore, for them to use hospital patients to make a warning about outpatients is a fraud. And in fact, that they did this is because it's obvious that they had no data of adverse events in outpatients, because if they had those data, they would have said, we base this on data in adverse events in outpatients. And they didn't say that. So we know that they didn't have it. And of course, they couldn't have had it because they blocked it from the EUA from being used in outpatients. So this is a total fraud and a crime. And this crime led doctors and doctor regulatory agencies across the U.S. and pharma regulators across the U.S. to ban hydroxychloroquine across the U.S. states. And many countries that look to the U.S. for guidance also use this website to justify banning hydroxychloroquine. Remember, hydroxychloroquine is a legal drug. It's been used for 65 years. Any drug in the United States can be used for off-label, so there's no grounds to ban a drug ever for anything, no matter what. And the fact that these regulatory agencies were banning it, and they were all using the same language, means that this was a top-down affair that was put out by this part of the government that was acting as a rogue agency rather than basing on science. Okay, so people like me, kind of new to the science of COVID treatment, really didn't understand what that had been brewing. And this had been going on, as you are probably very well aware of, since the fall of 2019. In October of that year, your Minister of Health, Agnès Buzyn, reclassified hydroxychloroquine from over-the-counter to prescription only. She had no, as far as I could tell, she had no evidence to do this. The claim was that chloroquine was genotoxic, and since hydroxychloroquine was similar in structure to chloroquine, it should be limited. And this absurdity was in spite of 65 years of safe use of hydroxychloroquine by hundreds of millions of people in tens of billions of doses worldwide, in children, in pregnant women, in infants, and frail elderly. This reclassification seems to have been publicly acknowledged in January of last year, but it occurred before there was public knowledge of the likelihood of a pandemic happening. And we know that Buzyn's husband, Yves Lévy, was head of INSERM at the time, and we know he's had a running antipathy for your institute. And he was present at the inauguration of the Wuhan Institute of Virology BSL-4 lab in 2017. And this is, again, the kind of corruption that needs an investigation. If you haven't done it through a Freedom of Information Act or some form of investigation and prosecution, it really needs to find out what was going on about all this and why this was happening in 2019 before there was any knowledge of an epidemic going on. And so these machinations, and there's an excellent paper by Muccielli in the Journal of Sociology from June of last year, describing all of this interference. All this occurred before the idea that there was an epidemic coming, before it was widely known to the general public. Now, as the spreading of the epidemic was occurring, this strange paper was published in February of last year in the New England Journal. It must have been written in January, again before people understood that there was this pandemic coming. This paper, The Magic of Randomization versus the Myth of Real-World Evidence, claims that randomization always creates perfect studies and non-randomized studies are just garbage, are evidentiary rubbish, as I've called it. And in fact, it's a lying screed against my entire field, my entire discipline of epidemiology. When I first read it, I was just antagonized, just made me really angry that they would write these lies and this nonsense. And so then I looked up the conflicts of interest of the authors and realized that they were all mainly funded by pharma companies. And you might notice that the third author, Martin Landry, is the principal investigator of the fraudulent recovery trial. So what I didn't realize at the time was that this paper had a purpose. It was a setup to block all non-randomized trial evidence that the pharma and vaccine companies knew would be coming. And they knew that if there were randomized trials that might show benefit of hydroxychloroquine, they would take longer to carry out. And so they could wait to try to block those. But in the meantime, non-randomized trials take less time to carry out, and so they had to put up some interference, and so they wrote this paper to block those kinds of studies. Now, you can guess that this magic paper didn't discuss the fact that for randomization to work, it requires hundreds of outcomes in each arm of the trial. Otherwise, a randomized trial is no better than a non-randomized trial. People don't really understand this, that randomized trials have to be designed not for the magnitude of benefit, like a twofold or 50% reduction in outcome. They have to be designed so that the randomization works well enough, and that can take 10 times the number of subjects in each arm compared to what you think would be needed to find an outcome. And so small randomized trials that you see of 100 or 200 or 500 people are useless. They're no better than non-randomized trials on the basis of randomization. The magic paper also didn't discuss that randomized trials are totally easy to subvert in full public view. That all you have to do is design them for unrealistic magnitudes of benefit, stop them early, use subjective outcomes, or change the outcomes in the middle of the trial. Don't validate the participants of their outcomes. Do it by the internet, for example, so you have no idea who the real people are who are participating or what the real outcomes are. Ignore the medication shipping delays. Use recognizable placebos that people can tell the difference. Give inadequate doses or toxic doses. Draw conclusions from part of the results and ignore the inconvenient results that you don't want to talk about. Generalize the conclusions much wider than applying to the actual subjects that are in the study. So all these things are tricks that people who want to make their trials show null results, zero associations, they do, and in fact were done in the randomized trials for hydroxychloroquine. The magic paper also didn't discuss the paper that was written by the ex-Centers for Disease Control director Tom Frieden that he had written about in the same New England Journal in 2017, where he said that non-randomized trials convey equally, if not sometimes better evidence than randomized trials. So they ignored all that. And the most important thing that they ignored was this paper in the Cochrane Library Consortium. The Cochrane Library Consortium had commissioned what is an extraordinary review in 2014 comparing randomized trials to their corresponding non-randomized trials of the same exposures, same drugs, same outcomes. This involved more than 10,000 individual studies in total and was carried out by a meta-analysis of meta-analyses. So all of these studies that are listed here were meta-analyses, each one having hundreds to thousands of studies involved that it looked at. When they summarized this whole body of literature, they showed that the difference between the observational non-randomized studies and the randomized trials had a relative risk of 1.08, an 8% difference that was not statistically significant, giving empirical evidence that well-conducted non-randomized trials give just as good evidence as randomized trials. And so this paper, this Engelmeyer paper, is the evidence, the empirical evidence, why evidence-based medicine, so to speak, that claims only randomized trials are valid is a shibboleth. It's false. It's the evidence why Fauci's statements that non-randomized trials are anecdotal are basically lies. It's the evidence why FDA saying that it requires evidence from randomized trials before it can approve medications is also a fraud. What that fraud does is it limits drug approvals to large companies that can afford the $50 million or greater costs to do those kinds of studies. And this whole thing is why in 2016 the US Congress passed the 21st Century Cures Act, which in section 3022 requires federal agencies to use other forms of evidence in addition to or instead of randomized trials to make decisions about the appropriateness and effectiveness of medications for their approval decisions. The FDA, of course, has totally ignored this law in the emergency use authorization requests that it's had two of them that have come from Henry Ford Hospital in Michigan asking for outpatient use of hydroxychloroquine, and the letters that the FDA has written back saying no, say we're waiting until you supply us with multiple large randomized trial results, which is a total violation of this law. So what I'm describing is, and what I do, and what I think is what scientists should be doing and normally do, is to use whole bodies of scientific knowledge. And that's what lets us make decisions about causal relationships, to use all of the scientific evidence to draw conclusions, and not just randomized trials or any other specific limited form of evidence. And this was laid out by Sir Austin Bradford Hill in 1965. It's his, what is called his classic rubrics of aspects of causal reasoning. It's withstood the test of time. It's used worldwide by scientists as the general go-to methodology for addressing significant statistical associations as to their potential causal relationships. And this is how science is done, not by randomized trial fetishism. Now, so before I go ahead and discuss what I think is the evidence that talks about the efficacy of hydroxychloroquine in early outpatient treatment, I want to talk briefly about the junk studies, the studies that were put up to fail, that tried to counter the benefit, the studies that actually do show evidence. I'm only going to talk about early treatment studies that have data on mortality or hospitalization risks, and not on the pre-exposure prevention and the post-exposure prevention studies. That's a whole topic by itself, and so for another time. As of now, there are 5 main, what I call contrived to fail hydroxychloroquine outpatient randomized trials. The first of these 4 were published last year. The Schwartz paper from Canada just came out on Monday of this week. So just to set the stage, I'll point out that both Boulware in the Minnesota studies and Mijai in the Catalonia studies had active pharma conflicts of interest at the time their papers were published, and neither author disclosed those conflicts of interest in the materials that they supplied with the papers. And we found those conflicts of interest by searching from documents that were found on the internet. So Boulware's first prevention study was one in which, done by internet recruitment and web-based study subject ascertainment and monitoring. It followed up subjects for risks of hospitalization and mortality. It had a little over 800 asymptomatic healthcare workers who were presumed to have exposure to the virus. or to the virus-infected individuals, and they were randomized about 50-50 hydroxychloroquine or placebo within a few days after exposure. The first problem with this study is it involved low-risk individuals, median age 41 years. Remember, we talked before about, and my claim was that this works for high-risk patients. Theirs was a low-risk patient study. The authors avoided accounting for the shipping time for the medications, so it took longer than they asserted for the medications to be starting to be used. And because these were such low-risk people, the study was uninformative. There was one COVID-related hospitalization among the placebo patients and one among the treated subjects. This is just not informative. There were no deaths reported. And then the authors concluded that there was no benefit. And this is absurd because the study is uninformative. And if the study is uninformative, you don't claim there's no benefit. You say the study doesn't bear on the subject because we don't have enough data to make a statement. Then they did the second study, again from the University of Minnesota. It came from the same large sampling frame. This was published by Skipper et al. And in this study, they had symptomatic, non-hospitalized adults with laboratory confirmed or probable COVID-19 and high likelihood of exposure, and randomized within 6 days of symptom onset 50-50 to hydroxychloroquine or placebo. And again, followed up for hospitalization and mortality. Again, low-risk individuals, median age of 40 years, didn't account for 1 to 2 days of medication shipping time. The study was slightly informative. There were 8 COVID-related hospitalizations in the placebo patients and 4 in the treated subjects, which gave a relative risk for hospitalization risk of 0.5. But it wasn't statistically significant. No deaths in the study. And the fact that they had 8 and 4 hospitalizations means that the randomization was, again, 100% useless. There's no way to know about the covariate distributions in these outcome patients. They're not described, and randomization just doesn't balance it in small numbers. However, these small numbers didn't stop the publication of this paper and other papers like it in top journals, because these journals are biased against hydroxychloroquine positive results. And so that's why this got into the annals of internal medicine, when it should not have gotten into anything. And then again, the problem is the authors concluded no benefit was seen, rather than the study showed a significant 50% reduction, a non-significant 50% reduction in risk. People, they get away with confusing the magnitude of the benefit with the statistical significance. And every epidemiology student knows that significance is only how you got to the result, but not what the result is, that the magnitude is what the result is. Okay, now we turn to the Catalonia studies. The first was a non-blinded randomized trial in which 136 patients were assigned to hydroxychloroquine, 157 to no treatment, no placebo, no blinding. Again, the study was low-risk people, age 42 years on the median. The study had slight numbers of cases, 12 hospitalizations in the control patients, 8 in the treated subjects, had a relative risk of 0.75, not statistically significant. 19 of the 20 hospitalizations were for pneumonia, and there were no deaths. Again, the small numbers of this make randomization useless. The second of these Catalonia studies was a cluster randomized study, and this had a larger number of people, 1,200 associated who had hydroxychloroquine, 1,300 with no treatment. Again, they were mostly low-risk individuals. The median age was 49. It was actually lower than this, except for one subset, which I'll say in a moment. There were 12 hospitalizations among the controls, 11 among the treated subjects, with giving a relative risk of 1. And again, these were hospitalizations for pneumonia. The authors didn't say whether they thought these were COVID-related hospitalizations. Again, I would say that the study is slightly informative, and if you looked at the deaths, there were 8 deaths among the controls and 5 among the treated subjects, giving a relative risk for mortality of 0.68. Again, these small numbers make this study essentially useless by randomization. Now, one thing I would say about this study is that it included 293 nursing home residents. That's what pushed the average age up to 49. because they were older ones as a subset among everybody else who were younger. And nursing home residents are by definition high risk. And in these subjects, the risk of the primary study outcome, the study outcome was PCR confirmed symptomatic disease, was cut in half. And here it is, relative risk of 0.49 in these nursing home residents. However, this was in a figure at the end of the paper, and the authors made no comment about this in the finding in the paper's conclusions. The fifth study of these junk studies came out this week in the journal CMAJ Open. It was done in Alberta, Canada. And in this study, the province provided subject identifying information to the study investigators after they had done PCR testing and got the results of the PCR testing, and of the positive ones, reported those back to patients. So this whole administrative process had to occur before the investigators were even informed of the identities of the subjects. And what they got was 3,000 eligible patients for the study, but because of various administrative reasons and patient refusals, they ended up randomizing only 148, less than 5%, 111 to hydroxychloroquine and 37 to placebo. And you can address how representative 148, 5% of the total is actually. But the main study flaw of this is that with all these delays, that there was a median time of 7 days from symptom onset to randomization, and then another 1 to 2 days of time to ship the medications to the subjects. And this 8 or longer days on average to get to the subjects is longer than the 5 to 6 days of starting window, which we know is what's really required to get the effectiveness of hydroxychloroquine into people as outpatients. The earlier the better, as we well know. So this delay was even a day longer for the hydroxychloroquine patients than the placebo patients. And what the study observed is no deaths in either group, 4 hospitalizations in the hydroxychloroquine group and none in the placebo group. But of those 4, one of those patients never started taking the hydroxychloroquine. 2 of them discontinued early, and they didn't say even whether the hospitalizations were related to the COVID in the first place. So again, the small numbers of outcomes makes this a 100% useless study. And then, of course, the authors again misrepresented what the study found. They said there was no evidence that hydroxychloroquine prevented severe outcomes. And again, this is just saying, misstating the fact that what the study showed is that it didn't bear on the outcome because it was uninformative, because they didn't have any outcomes. So that's where we were left with the pushback, the misrepresentations. Now I'll quickly go through the evidence, because this is the meat of what we know about hydroxychloroquine. The first was the Sao Paulo Prevent Senior study, and here we had consecutive outpatients with 2 days of flu-like symptoms. They were offered treatment with hydroxychloroquine plus azithromycin. 224 declined treatment. They were the control group. 412 accepted treatment. The study outcome was hospitalization, and what they found is a 1.2% risk in the patients starting treatment before day 7, 5.4% for controls, relative risk of 0.22, statistically significant. The second study was in Brasilia. This was a social media medical clinics referral study. Patients were recruited into parallel treatments with various treatments, including hydroxychloroquine, ivermectin, nitazoxanide, according to the clinical judgment of the doctors treating the patients. All the patients also received azithromycin. Most of them who got hydroxychloroquine also got vitamin D, and half of those got spironolactone. The controls were newly symptomatic outpatients identified in the same sources, same time frame, who either declined treatment or weren't offered treatment and were given standard medical care. There were no hospitalizations or deaths in the patients given hydroxychloroquine, whereas 27 control patients were hospitalized and 2 died. The hospitalization relative risk is 0.01, mortality relative risk 0.17. Both of these are continuity corrected because of the zeros, because of the no events. The third study was your your own screening and treatment study, you had 60 patients, 68 patients 60 years or older, 1,500 patients that were treated, and compared to 520 patients who were given the medications for less than 3 days or only given the individual medications or not given either one. Your result was an odds ratio of 0.17, again, very, very statistically significant. And just to point out that your unexposed group included an appreciable number of patients that had used the medications but for shorter time periods or had used hydroxychloroquine alone, which means that your result is perhaps somewhat biased towards the null, that it's really a stronger result than this, because the controls had some degrees of exposure. The fourth study was your nursing home study. And here there were 226 infected residents from 23 nursing homes, 37 detected because of symptoms and 189 through screening. Multivariate analysis showed that hydroxychloroquine plus azithromycin for 3 days was associated with a mortality risk of 0.37, again statistically significant. The fifth study was another nursing home study in Andorra. Here there were 100 PCR confirmed patients. The median age was 85 years. Multivariate analysis of mortality risk adjusted for various factors showed that hydroxychloroquine plus azithromycin versus only other antibiotics besides this had a mortality odds ratio of 0.04, again statistically significant. Hydroxychloroquine with other antibiotics, not azithromycin, versus the other antibiotics had a relative risk odds ratio of 0.32, not significant, but still showing in the same direction. Then there was a nursing home mortality study in Milan. Here there were 157 residents tested and so on. 98 were positive and followed over time. Residents who had supplemented with vitamin D beforehand had a 5-fold reduced mortality risk. In the multivariate logistic regression models adjusted for everything, hydroxychloroquine was associated with a 7-fold reduced mortality risk, odds ratio 0.14, again statistically significant. One strange thing about this study was the authors made a statement in the discussion: hydroxychloroquine was prescribed only in patients with better ECG tracings and those receiving less drugs that might induce QT interval prolongation, such as antipsychotic and antidepressant therapy agents, thus being probably better or more fitter than those who did not receive this therapy. I thought this was ridiculous. In fact, it sounded like a disclaimer that was forced on them by the reviewers of the paper. And the reason for that is these antipsychotic and antidepressant medications have not been shown to provide 7-fold mortality reduction from COVID, and therefore it cannot possibly account for a 7-fold reduction of something that they're claimed to be a confounder for. Then the next study was the Hackensack Meridian, New Jersey study. This was one of people who came to the emergency room but were not admitted to the hospital. There were 97 who had been or were given hydroxychloroquine, and they were matched by propensity score matching to 10 to 1 to 970 patients who were not treated with hydroxychloroquine. This matching was on a host of demographic and comorbidity factors, lab tests, and so on. In their matched analysis, the hydroxychloroquine cut the risk of hospitalization by 46%, again statistically significant. The eighth study was our study from Brazil with my colleagues in Brazil, who looked at 717 consecutive PCR positive symptomatic patients over age 40. These were patients that were in the 42 outpatient clinics and emergency rooms of the 6 million member Hapvida HMO. The plan was to let the treating doctors give any ones if they wanted or combinations of 6 medications: hydroxychloroquine, azithromycin, ivermectin, oseltamivir, nitazoxanide, or prednisone. Prednisone started on symptom day 6. Everything else started immediately. And what we found in the multivariate analysis, adjusted for everything, that the use of both hydroxychloroquine and prednisone together was associated with an odds ratio for hospitalization of 0.4. Hydroxychloroquine by itself, odds ratio of 0.45. Prednisone by itself, odds ratio of 0.51, all significant. In this model, ivermectin did not show a benefit. It had an odds ratio of 1.17 adjusted for all these things. And even though the numbers of deaths were small in this study, hydroxychloroquine was associated with a reduced odds ratio for mortality of 0.22, though not significant. Then, as we go up in the numbers of subjects, the national study in Saudi Arabia, they had a national network that they set up of COVID outpatient treatment clinics. Over 3 weeks in June of last year, they treated 4,600 outpatients with cetirizine and zinc, and 330 patients they treated with the same thing plus 5 days of hydroxychloroquine. So almost 8,000 patients in total. Multivariate analysis adjusted for everything. Mortality risk was cut by 2/3. However, one interesting thing about this study is that in Saudi Arabia, all of the medical care records use unique national personal identifying numbers. And because the 8,000 study subjects were followed for hospitalization and mortality by the medical care system outside of the study, all of the data on their hospitalizations and mortality were available. And when you analyze those, it gives a mortality odds ratio of 0.18, hospitalization odds ratio of 0.57. Again, both very statistically significant. And finally, the national Iran study. And this was, again, a population-based study, a retrospective cohort study, almost 29,000 subjects with mild COVID-19 seen within 7 days of symptom onset in a network of healthcare centers across the country between March and September of last year. They had 7,300 or so treated patients who got hydroxychloroquine. 21,000 controls got standard of care only. The treated and control patients were very comparable in the distributions of age and sex. The treated subjects had slightly higher frequencies of comorbidities, as we've seen in most studies. Hydroxychloroquine was associated with a 38% reduction in risk of hospitalization, 70% reduced risk of mortality. Again, both very statistically significant. So I put together all of these studies in simple random effects meta-analysis to summarize what these studies have shown. Here's hospitalizations. You can see everything is more or less in the same direction, in the same, all showing benefit to one degree or another. The summary odds ratio is 0.56. It cuts risk of hospitalization in half. There's a bit of heterogeneity. The I-squared is 71%. It's really mostly due to your study, and I think it's maybe because you might have had slightly different reasons for hospitalizing patients. Maybe you hospitalize them more frequently, but for shorter durations than other places. You can discuss that later as to why that might have been. Here's mortality. You can see that the summary of these results shows that mortality is cut by hydroxychloroquine use by 3/4, fourfold reduction in risk of mortality. These results provide very strong evidence of the benefit, fourfold benefits of the benefit of this consistency across these 9 studies across the world. So we have both strength of the magnitude of association, fourfold, and consistency across different subjects, different populations, different countries that satisfies consistency across Hill's rubrics, Hill's aspects of causal reasoning. Very strong evidence. So you might think that those of us who study and use hydroxychloroquine are the friends of hydroxychloroquine that I was saying. And that's true in part. At the present, I've been involved in an email group of doctors who from early last year started contacting me, and this has grown to now about 800 people in it, mostly doctors. It takes me 3 to 4 hours a day just to get through my emails, and I don't even have time to watch the videos that people send me. And so these are the friends of hydroxychloroquine. But I also think of these companion agents that are used with hydroxychloroquine, the azithromycin or doxycycline, zinc, vitamin D, budesonide, colchicine, fluvoxamine, bromhexine, aspirin, etc. I also think of them as hydroxychloroquine's friends. So hydroxychloroquine works by itself, but not well enough, really, for what we want to accomplish. And these companion medications potentiate hydroxychloroquine's benefits quite a bit. Now, one medication friend that I haven't discussed is ivermectin. Ivermectin has also been discussed a lot in the media, and many claims have been made for it. And you might have noticed that in the previous funnel plots for hydroxychloroquine meta-analyses, I didn't show any of the hcqmeta.com figures that we know they've been looking at. That's this website here. Here they're saying hydroxychloroquine, 259 studies. I've got 10 studies and they've got 259. And the reason for this is that these analyses don't separate outpatient from hospital studies, which for me is crucial. And so I don't rely on their analyses. They're nice for public messaging, but I rely on the science that I do the way I do it and think best. So likewise, I don't rely on the IVM meta studies, COM studies, or any published meta-analyses for ivermectin for the same reason, that they don't separate the studies of outpatients from studies of hospital patients. And these studies make the mistake of saying that early COVID versus late COVID is the same thing as outpatients versus hospital patients, but they aren't. In Western countries, hospitalization for COVID-19 is what we epidemiologists consider a gateway event. People are hospitalized because it's too risky to continue their treatment at home, either because the medical technologies that are needed or the medical supervision and care that's needed. And usually the reason for this is disease progression as manifested by decreasing oxygen saturation. And this reflects the progression of COVID from its initial flu-like viral replication phase to its ARDS, florid pneumonia disease stage. Early versus late is not a good way to distinguish between viral multiplication versus ARDS. The fact of hospitalization is a better way. It's a discrete event where the doctors treating the patients make the statement on the basis of the care that they think the patient needs because of decompensation and progression. And so that, epidemiologically speaking, is a much better indicator for what the patient's disease status is. And also, of course, you can't study hospitalization risk for people who are already hospitalized. So I do my own meta-analyses. And I won't go through all the individual IVM studies like I did for hydroxychloroquine. I'll just say that I included every outpatient study that I could find that had data on hospitalization and mortality. But one caveat is that as an epidemiologist, I require studies that have control groups to have control groups drawn in a way that's representative of the cases. And so a number of these studies did not have control groups. They had artificial control groups that were sampled from some other form of data that I don't accept as a comparable form of controls. And so for the ivermectin studies, that's Carvalho, Chowdhury, Goriel, and Morgenstern, I don't accept those as accurate studies for doing a meta-analysis, just like I omitted Zelenko's study from the hydroxychloroquine meta-analyses. So here we see for hospitalization that IVM has a clear signal that it shows a relative risk, an odds ratio of 0.31 for risk of hospitalization, but there's a lot of heterogeneity. This comes mostly because of our study in Brazil. However, I'll say that even though this shows a lower risk of hospitalization than the hydroxychloroquine studies, the statistic for whether those odds ratios are different is a p-value of 0.17. So statistically, they're not distinguishable. You can see the confidence limits for this result are wide. Here's the mortality analysis. Now, this is much more problematic. This study, you can see, is based on 87% of the weight in this analysis is for the one study by Lima Morales. And in this study, they used a single dose of 12 milligrams of ivermectin, and at the same time, they also included full treatment courses for azithromycin, montelukast, and low-dose aspirin. And so you can't claim that ivermectin conveyed this benefit when all these other things are involved in the treatment, and especially this low and single dose of ivermectin when all these other things are involved. And so the fact that this is a large study, carries 87% of the weight of this meta-analysis, and has basically a not really credible amount of treatment in it, says that the evidence that's conveyed in this study is weak, and therefore the whole evidence for mortality is relatively weak. And you can see also that this is reflected by the large confidence limits that are shown here. So what we see is that the hydroxychloroquine studies have involved more than 40,000 patients, whereas the ivermectin studies only about 5,000. And thus that the evidence for hydroxychloroquine is much stronger than for ivermectin. So just to kind of sum up, here are the four plots. For hydroxychloroquine on the top, ivermectin on the bottom, hospitalization on the left, mortality on the right. You can see the evidence for hydroxychloroquine is much stronger than the evidence for ivermectin. Now, just my take-home message from this. We've been involved in a battle to get hydroxychloroquine validated and allowed for the use of COVID patients. And you know that when you fight a battle, if you're not close to the target, your enemies don't bother. They don't waste their ammunition fighting back. And because our biggest fight has been to support hydroxychloroquine, that means that the actors, the agencies, companies, or whatever, standing to lose the most from it, have been fighting the hardest against it. So if the fight is hardest against hydroxychloroquine versus ivermectin or other things, you know that your enemies think that it's the most damaging battle that they have to fight. So that means that they know that it works for early outpatient treatment, even as they corrupt the public messaging to pretend that it doesn't. And that the same degree of fanatical pushback has not occurred for ivermectin, in spite of the what I'll call theatrical presentation by some of its advocates, suggests that the actors standing to lose on the basis of usage of ivermectin are less threatened by ivermectin than they're more threatened by hydroxychloroquine, which means that they think that ivermectin doesn't work as well as hydroxychloroquine for outpatient treatment. And I completely agree on this. And this is the battle that we're fighting. And so even our friends, you would think in the ivermectin people, and I'm not saying that ivermectin doesn't work. People, it should be used, and we can talk about that. But that even our friends sometimes aren't always our friends, and we need as many friends as we can. So thank you very much for listening, and happy to talk about any questions or observations.